Good afternoon, dear students. We are going to start with the topic red and white lesions, part 2. In this part 2 of red and white lesions, we are going to discuss about the classification, etiopathogenesis, clinical features, and treatment of oral candidiasis. So the learning objectives are mainly to know what is oral candidiasis, so its definition and classification, explain the predisposing factors of oral candidiasis, discuss the acute and chronic forms of candidiasis, and the treatment of oral candidiasis. And all of these are in the must know category. Contents are as follows. Now, what is candidiasis? As you all know, candida is a normal commensal in the oral cavity, in the oral microflora. When there is multiplicity or increase in the number of candida, which usually occurs in a diseased condition, then there can be candidiasis. So, candidiasis refers to a multiplicity of disease caused by yeast-like fungus candida and is the most common oral fungal infection in humans. Now, the predisposing factors which can lead to the multiplicity of the fungus candida in the oral cavity can be changes in oral microflora which can occur in the presence of any antibiotic therapy or any medications the patient is having, or even in xerostomia, or it can be related to age changes relations. Oral microflora can also be changed in patients receiving radiotherapy. The next is the local irritants. Local irritants can be a fractured prosthesis or fractured tooth, or it can be just a sharp cusp irritating the mucosa. Drug therapy can include various the drugs on which the patient is since a longer time. So drug therapy alternatively it affects the quality as well as the quantity of the saliva, and by that it affects the oral microflora, and thus the patient can have candidiasis. Acute and chronic diseases, any systemic acute chronic diseases which the patient can have can affect the oral microflora, which can lead to candidiasis. Malnutrition status, age, endocrinopathy, immunodeficiency, again all these conditions they affect the oral microflora as well as the salivary flow, leading to changes in the quality as well as quantity of saliva, which changes the oral microflora, and thus it can lead to increase in the number of candida and therefore the manifestations of candidiasis. Now let's look at the classification of oral candidiasis. Oral candidiasis is classified as acute and chronic form. The acute form includes pseudomembranous or thrush, and the atrophic or the erythematous form includes the antibiotic stomatitis. Under chronic, there can be atrophic candidiasis, which is also called as the candida associated lesions, and the subtypes are dengue angulocheilitis, median rhomboiditis. The another type under the category of chronic candidiasis is hypertrophied or hyperplastic candidiasis, which includes candidal leukoplakia, papillary hyperplasia of the palate, and the median rhomboiditis. Then next is the multifocal, means the candidiasis which can be localized in multiple areas in the oral cavity. Mucocutaneous, involvement of cutaneous as well as mucosa is there. So under this category there can be syndrome associated, which includes the familial, or which can be with or without endocrine candidiasis syndrome. And second is the myositis, thymoma associated. Next, the candidiasis can be localized or it can be generalized involving different systems as well, or it can be HIV associated. Oral thrush is the prototype of oral infection caused by yeast-like fungus, and it is nothing but a superficial infection of upper layer of oral mucous membrane and results in formation of patchy white plaque or flecks on mucosal surface. The clinical features can be different in infants and adults. Now in infants, especially in the neonates, in the 6th to 10th day after birth, curd-like pseudomembranous material is visible on the mucosa, and it is said to be infection from the maternal vaginal canal, but many times the cause is not known. Lesions are soft, white, bluish, white adherent patches, and they are mostly painless and they are noticed only on examination. Whereas in the adults, the sites are different. Roof of mouth, retromolar area, and mucobuccal fold would be affected. And the patients in the adult category, they have prodromal symptoms like rapid onset of bad taste and discomfort from spicy food. So the burning sensation and dryness of mouth are a persistent finding in adults as compared to infants in whom these findings are not present. To see the signs, they are inflammation, erythema and painful eroded areas. If you try to touch the area, it will be very painful. Sometimes typical pearly white or bluish white plaque are available. Most of the patients show these features. Multiple curdy loose adherent patches are there. If you try to scrape the patches with wet gauze, it will be scraped off, and what is left beneath is just normal or erythematous or an atrophied area. There can be deeper invasion, and if this happens, then it can lead to ulceration of the lesion, especially of the underlying erythematous areas, and occasionally it can be associated with dysplastic changes. So if the patient does not respond to therapy, such lesions should be investigated by histopathological examination. This is a typical picture of pseudomembranous candidiasis. You can see these are the whitish plaques, curd-like material on the palate. If you try to scrape this off, this will be removed, but then beneath there can be erythematous red areas which could be painful. This is another picture of an immunocompromised HIV patient having multiple pseudomembranous patches on the tongue, buccal mucosa, along with erythematous areas. So a very painful condition. If histopathology is done, then what can we see? Fragments of plaque examined will show hyphae, presence of yeast cells and hyphae or mycelia in superficial and deep layer of epithelium can be there. So, but routinely histopathology is not done. Just scraping can be taken of the plaque, and that can be visualized on a histopathology slide. The differential diagnosis includes lichen planus, leukoplakia, and the chemical burns. So the lichen planus has the presence of Wickham's triad, which is very pathognomic for it, so which is absent in the candida. So in that way, it can be differentiated. Whereas in the leukoplakia, which is a homogeneous type, and the lesions are non-scrapable, which is just opposite of the thrush, in which the lesions are scrapable. Chemical burns, the patient will typically give you history of burn from a chemical, say for example aspirin application or a sodium hypochlorite solution which might have been applied to the patient while treatment, and that area got burned, and typically it appears as erythematous area covered by pseudomembrane. So the history of application or contact with the chemical in this case is very important. Acute atrophic candidiasis, we have seen in the previous slides about pseudomembranous candidiasis or thrush. Now here we are going to discuss about the acute atrophic candidiasis. So acute atrophic candidiasis, it represents a red patch of atrophic or erythematous raw and painful mucosa with minimum evidence of the white pseudomembranous lesions observed in thrush. And it is also called as an antibiotic sore mouth because usually the patient gives history of intake of antibiotics few days prior, after which there is change in the oral microflora leading to increase in the number of fungal infection and therefore the appearance of this atrophic candidiasis. So the classical clinical features in atrophic candidiasis are the lesions appear red or erythematous rather than white, which we have seen in pseudomembranous candidiasis. Usually involves the tongue and tissue underlying an appliance. Symptoms are vague pain and burning sensation. The signs can be examination reveals few white thickened foci that rub off, leaving painful surface. Lesions resemble the erosive lichen planus or the erythroplakia. But then how to differentiate it from this? Erosive lichen planus will have an Wickham's striae in the oral cavity. If you thoroughly examine it, somewhere or the other you will be able to find the Wickham's striae. That way we can differentiate it from erosive lichen planus. Whereas in erythroplakia, the lesion is a very well demarcated, well defined lesion. Whereas in candidiasis, the lesion is not that well defined or well demarcated. It will have a diffuse periphery. In that way, it can be differentiated from erythroplakia. Histopathologically, the atrophic epithelium will contain few hyphae in the superficial layer, and the differential diagnosis is chemical burn, drug reaction, syphilitic mucus patches, necrotic ulcer, gangrenous stomatitis, and traumatic ulcer. All these conditions, they have an erythematous appearance of the mucosa, and therefore these will come with differential diagnosis of atrophic candidiasis. But as I said, always look for the etiology. Like in chemical burn, the chemical history, contact history will be there. In drug reaction, intake of drugs history will be given by the patient. In syphilitic mucus patches, definitely if you go for the proper investigations, lab investigations, they will help you in differentiating it from syphilis. Similar for the necrotic, gangrenous and traumatic ulcer. These will have a very typical etiology which will help in differentiating from these entities. Next is the chronic atrophic candidiasis. They are also called as the candida associated lesions. The chronic atrophic candidiasis includes denture stomatitis or the denture surmount, angular cheilitis, and the median rhomboid glossitis. So let's start with the denture stomatitis, also called as the chronic atrophic candidiasis. The clinical features are that these, as the name itself suggests, that this is a condition is seen in patients who are wearing dentures. So found under complete or partial denture, and mostly in women, and always it will include the palate. Patchy distribution of speckled curd-like white lesion is seen. Like if the patient removes the denture, the underlying mucosa of the palate, you can see it to be having curd-like speckled, the red area which is speckled with curd-like white lesion, and it can be painful to the patient. There can be dryness of the mouth as well. So the palatal tissue is bright red and erythematous. Multiple pinpoint foci of erythema involving the maxilla can also occur. So why only palatal mucosa is affected and why not the mandible? The palatal mucosa is affected mainly because of the negative pressure which is built between the denture and the mucosa, which inhibits the flow of the normal saliva. Salivary action of cleansing is not there, and therefore there is hypoplasia of the candida. Candidal infection increases in that condition. Whereas if the mandible is involved, then in case of mandibular denture, there is sufficient cleansing effect by the saliva which prevents the growth of the fungal infection. Therefore, denture stomatitis mainly seen with the upper dentures. Histopathologically, they can be atrophic epithelium with superficially oriented mycelial cells. Differential diagnosis in this condition can be allergic reaction to denture base or the erosive lichen planus and dermatitis herpetiform. Now, if there is an allergic reaction to denture base, then this type of lesion can appear after using the denture for the first time. So, allergic reaction will not take a longer time, but those reactions will be seen within a short duration after using a new denture. Erosive lichen planus patients will have Wickham's striae. Again, I am specifying Wickham's striae, which will help in differentiating the erosive lichen planus from the fungal infection. The management includes troches of clotrimazole and nystatin for 4 to 5 times after meal and bedtime.